Hello everybody, can you hear me? Yeah, hi. As you can probably see, we've come as a treble act today. So there's myself, I'm Ailsa, I'm a GP in Rossendale, which is on the edge of East Lancs. And the whole point is about teamwork. So Denise here is team leader and Wendy, health visitor. So we're going to talk you through some of the things we've been doing. We've called this the Rossendale Paediatric Hub. Hub is inverted commas because it's partly a place and partly a concept and partly a sort of virtual team, a real team, but we're necessarily in a real place. What I'm hoping is that you won't find this mind-blowingly complicated, but actually this is just examples of what is probably common sense, ways of doing things differently that we've tried and that have worked. So we're going to go through, talk about some examples, give you some real scenarios, and hopefully that'll catch your interest, and it's about how we can do things differently. So what's it about? That's what it's about. Who is involved in this Rossendale hub? It started off between secondary care, primary care, looking at whether we could do things differently, and we'll talk about the other team members that have come on board in that process. I'm going to talk about what we've achieved, mostly with examples. Talk about a multidisciplinary team, which is a community-based multidisciplinary team, so the typical process and some of the outcomes. And we've also looked at pathway redesign and also where we're hoping this will go in the future. So why did we begin this? It seems a while ago now, a couple of years ago probably we first talked about it. I think there was and there still is an awareness that things aren't sustainable as they are. We need to do things differently. And we wanted to be involved in that, seeing it as an opportunity, not just a threat. And the teams involved in patient care want to influence that patient care. We see, especially in primary care every day, numerous families, children. We wanted to be involved in knowing what happens locally and how we can influence their health. We know, we were talking earlier, haven't we? We need to develop workforce. We need to attract people and keep them, retain them, and hopefully by doing things differently, with a different, perhaps, job role or a different way of looking at things, that will entice people and get them to stay. That's basically the grow your own workforce. Particularly, we found this helpful for people coming up through training grades or medical students or anybody to see us doing things differently. Hopefully we can grow them and they will stay in the Northwest with us. We wanted to recapture some of more a collaborative working relationship. Some people, like myself, have worked in the NHS for a long time, and we always used to be able to get hold of each other and talk to each other a bit easier. It seems to have all disintegrated somehow, so it was trying to recapture some of that ethos and work together across different professionals. And certainly it also started from a GP Federation point of view, wanting to look at how could other GPs across the patch in other areas, in other localities, learn from either this to completely different projects, or hopefully to spread out these projects. So the starting point, I've put as 2017, I'm not sure if that's right, but it was about GPs. There were many professionals, many GPs across Rossendale and the paediatric team from ELHT who agreed that we wanted to work together to improve children's health in that patch. It's a little way from the hospital, or quite a distance for some parents to travel, so it seemed an area that this made a lot of sense to start. So the things we were thinking about was including maybe bringing more of the paediatric services out of the hospital where appropriate. The consultants already coming out to Rossendale to run clinics, but could we do that a bit differently? Helping people to maintain those healthy lives, to try and decompress the whole system to keep people healthy in the first place. And to simplify some of these ways of parents accessing healthcare can be mighty complicated. If we could simplify that in any way, that would hopefully help everybody. We had these ideas, we had this meeting, and then we discovered, I think it might have been Vanessa that pointed us in that direction, that Imperial in London were working with the King's Fund and had actually set up something slightly similar. So please don't feel we've just pinched their ideas. We were thinking of all this to start with, but as ever, if we can base it on what we know people have already found has worked, then that gives us ideas, credence, other things. What they were doing is they had children's health hubs, and that was based within 2 or 3 general practices with the St Mary's consultants. Our equivalent of theirs has been looking at specialist outreach and developing a Rossendale MDT rather than just outpatient clinics. We called open access, which was how do we get hold of people easier? How do we make it easier for families to access care? And we've also been looking at patient engagement. The things in brackets are how we've done it. those three, the specialist outreach, the open access, the patient engagement, were Imperial's way of defining their work. And that is their model. And as you can see, they've still got children and young people and their families at the centre, and that's still our hope as well. So the main part we've probably enjoyed most has been the multidisciplinary team. So who's involved? So the contributions and the people attending have expanded as we've been doing this. So clearly there are GPs from lots of different practices relating to who has the patient list that those families belong to. Our consultant, Dr. Gardner from ELHT, has been amazingly enthusiastic and supportive all the way through, and unfortunately couldn't be here today. Health visiting team, amazing. School nurses are so on board. It's been wonderful. And then we've found that a lot of the time, because we're talking about complex cases, we needed probably a bit of safeguarding advice. And this has been the ELHT safeguarding team. So we've kept it all within health at the moment. And then ALCAS, CAMS, we have primary care workers who are out mostly helping us in primary care about those referrals, and they've been very helpful as well. More on the sort of balance between needing to refer up to those services versus the child and wellbeing service, which is run by LCC. And they've been very welcome. And of course, we've had management input to try and keep us on track, help us make things work, really. So what have we achieved so far? So with the MDTs, we've now had regular MDT meetings. They've been monthly. And Rossendale is about 70,000 population. So we've bobbed from one end of the valley to the other each month. So in effect, each GP list or GP's practice has the option every 2 months of referring into that team. The health visiting school nurse teams spread across, to some extent, the valley. So they've often been involved with taking cases to both types of MDT. It was originally, or it still is, from a time point of view, based around when the consultant is already in Rossendale doing his outpatient clinic, so that hasn't been too disruptive. And as I said before, attendees of the list has been growing. What we've also found is it's great for training. Any GP trainees, we've had AMPs attending, medical students. It gives them that chance to fairly quickly understand roles of other healthcare professionals. And as mentioned, school nurses, health visitors, etc. And on the end, the smiley face is the recent additions, as I mentioned, to our team. So typical conversations. Denise in a little while is going to give us a really good example, but these are the kind of things we've tended to talk about at the MDT. So a lot of it's been advice on paediatric management. We're a little bit concerned. Do you want us to work up this child a little bit before we send them to paediatrics? Do we actually need to send them to paediatrics? So there's been a lot of cases like that, which we're hoping or we know have saved outpatient appointments. I think, as ever, it's a little bit difficult with data because it's difficult to prove you're not doing something. So we still have to get our heads around that a bit. Coordination of complex care. If people, children, families are needing lots of healthcare professionals, and that's an ideal place to share our management plans and concerns and talk about things. We've arranged investigations before clinics, so I've put e.g. obesity there. So, for example, a child that you're concerned about obesity, do they actually have an underlying condition? Do we need to do any more investigations? Do we just reassure them? What we've been able to do is arrange investigations outside of paediatric clinics, consultant review them, and then they've not needed to be sent further up to clinic. It's also worked the other way around. I remember there was a child with asthma, and mum came to see me. Child been in a couple of times, and somewhere had been advised they needed referring back to paediatrics for a respiratory review. And I was thinking, I'm not quite sure why. This seems very well controlled. Not sure what the benefit would be. And when we discussed it at the MDT, what had been really helpful was the consultant could look through those admissions, find out whether there was ongoing concern, look at what the reason might have been for suggesting referral in. And actually the answer that came back was no referral was needed. And that actually when he'd realised that the child was registered with our practice and the practice that went to the MDT, he was quite happy that he didn't need to see that child because we'd bring the child back if needed. So that, again, saved parents having to go back for a review. And obviously, we're hoping that we can review more children in the community rather than in hospital. And our long-term aim is maybe we could see children at an MDT-type setting, actually bring them into a clinic rather than needing to go up to hospital. Challenges, aren't there always challenges? I think the main thing we've struggled with is the background admin support to coordinate this. So what we're doing is, in effect, between ourselves, emailing, obviously confidentially, information relating to the cases and trying to keep on top of them, review them, track them. So it's getting some kind of background system between primary and secondary care so that we can actually track these cases properly and provide data for which to look at a definitive, quantitative rather than qualitative outcome. Availability of professionals, we're all very busy, aren't we? And we're just having a little rethink about GP ability to attend. Because interestingly, one end of the valley, which has big GP practices in, so it's easier for us for somebody to go to a clinic because others can cover. If you're a single-handed or there's only two of you, to actually be able to practice is very difficult. So we're looking at maybe we can get some Skype way of introducing it. Maybe we can get the IT to work for us a bit better to reduce the amount of time that professionals need to take out to get to the MDT. GDPR, we all had a little bit of a panic about, but we seem to have got over that one now. One of the GDPR leads came to have a chat at a meeting, and we're much reassured about that. And the other thing, which I think we always find frustrating, is you think if you have a good idea, you can do it, but actually it takes time. So that's been a big learning point for us, but we're determined to carry on. So our plans, just mentioned IT, looking at Skype, hopefully we can have some meetings like that. We do aware that there may be other healthcare professionals that we need to perhaps invite in for specific cases, not need to have them having their time there all the time, but paediatric dietitians, for example, again, if they could Skype in and advise us, that would be really useful. And as I mentioned, hopefully we'll be able to see some actually at the clinic, and we certainly are very pleased that we think we've saved quite a lot of travelling up and down East Lancashire because of this. The hope would be that maybe we could do this in other localities, but I think we probably need to get to the bottom of the IT and the ability to spread it out a bit more first. So that was the MDT bit. We also had a concept about open access. This, I think, is about communication. And we were saying in the car on the way over, weren't we, that actually the mind-blowing innovation we've had with this is that we speak to each other. And that's probably made all the difference, yeah? And the consultants very kindly have risked giving the GPs their emails and their secretaries' emails. I'm hoping we haven't abused it, but that means we can get hold of people. So particularly if a child is under review from a consultant, if we can get hold of people and communicate more effectively, that benefits everybody. There's been the single point of access for paediatric referrals into ELHT, which wasn't particularly because of this project, but it helped that we could jointly look at referral forms and ways of doing that, and that's certainly, from a general practice point of view, helped significantly. And the other thing is we do talk to each other more. We have much greater understanding of each other's roles, and I think that's helped significantly. So our plans for communication. Some of you might have heard of something called GP TeamNet. We're hoping this is our all singing or dancing solution, but I'm not quite sure yet. This is a portal. We're hoping we'll have a portal whereby, as we develop pathways, we can push that information out to people. They have easy access to that, and then they can search on it and find it amongst all the thousands of bits of information that come out to them. We're hoping as well, we had an idea right at the beginning that we're still working on about like an FAQ bulletin board. I am sure that advice is asked of paediatricians, the same advice time and time again, and it would be really useful if we could post that advice somewhere so we don't all have to keep asking the same question. Big problem so far with GP TeamNet is the health visitors and school nurses don't have access to that, so we need to work on that because that would cause a significant problem. And it's all got a bit muddled up on the slide there, but we're aware that in communication we do need to involve families now more in how they think things are going, and also with pathway design, whether it's appropriate for them. We're definitely looking at streamlining pathways because we now have communication across all those healthcare professionals. So the ones we've concentrated on, we chipped in really with the asthma and childhood wheeze, which was run across the Pennine Lancs, both CCGs. And I think the main improvement for this has been that now EMIS has our asthma action plans. So we're all using the same asthma action plans, the same as the local hospitals. So we've got a consistency of message there between ourselves and for parents. Infant feeding, which is what Wendy's going to talk to us about in detail in a few more minutes, very much about early intervention, demedicalising or not escalating to medicalising what's a normal condition and reducing anxiety. Constipation is being worked on, and an allergy pathway as well. So our plans, we had this great idea, which we're still sticking to, is that in spring 19, we're going to have these pathways up and running and launch them across Rossendale. We'll need the supporting online resources. We'll need those pathways to be able to be pushed out and people to access them. We'll need to have training events at the same time and obviously some publicity. So that's the timescale we're running on at the moment. Benefits. I think there's been loads of benefits, and hopefully my colleagues will back me up. So I think there's been significantly improved understanding between all our different roles. And we have different skill sets, and it's enabled us to complement each other's skills. I think we now have valued professional relationships with shared values. We were talking earlier, weren't we, about looking after each other. And I do see this as being a way forward. We've got a bigger team and lots of people you can seek advice from. So I'm sure that helps us. Very much has fostered a willingness to everyone to work together, and we're determined to carry on. It's taken time, but we have managed to effect change. And we truly believe that children have benefited from this. For example, not needing a hospital appointment, healthcare professionals more confident because they've come across something in an MDT, they're happy to give advice. Newer services like the infant feeding. We have seen that we can do things differently between primary and secondary care, and there's a lot of opportunities this has generated and will continue to do so. Now, Denise is kindly going to talk about one particular case for us as an example.
Okay. Can you do slides? Hope you can all hear me, but actually if my managers that are here would say I don't need a microphone because they can hear me wherever I am. But anyway, just moving on quickly, because mine, basically for me, this is about actually the quality service that as a team we are giving to children and families out there, and also that they are getting quick responses, it's safe, it's effective. So the example is, what I want to go through is just, I fortunately was involved in a child health clinic, something that I don't always get the chance to get there now, but I was. And this mum that came to me was a mum with 4 children, but she had twins. And these twins had been born at 36 weeks, but one baby had been intubated at birth, and the baby that had been intubated, she was quite concerned because this baby was a really noisy breather, feeding fine but a really noisy breather. So to me, I examined him, we looked at him, we did all the observations, what you would do as a health visitor within a baby clinic, weighed, measured him, did everything. However, I could see this mum really anxious. So at that point, I thought, where do I go here? So I asked for consent, and I said, would it be possible that I can discuss baby for you at an MDT meeting with Dr. Gardner? We do have, if you want to, if you just press the slide forward, the next one, I think it is. Is it not on?
I don't think so.
No. It was just that we do have a referral. So we have a referral form because obviously we need to keep an audit trail. So I managed to quickly do through the referral form because the actual MDT was the day after. And we discussed this with Dr. Gardner the day after, and I explained that Mum was obviously quite concerned because she felt that this baby could have been traumatised at birth and that there was something significantly wrong. So what we decided was what was the best way forward for a quality service to this parent. And what Dr. Gardner asked me to do was to get Mum to video this baby, because she was saying he was doing this all the time, so we could significantly see if there was an issue. And she would send that to his secretary. So I spoke to Mum, and obviously the video that she had recorded went to his secretary, and eventually, within quite a short space of time, Dr. Gardner actually reviewed this baby's video, and this baby was normal. He had no concerns. And Mum was absolutely totally grateful about that because we had saved, obviously, GP appointments. We'd saved the time for the mum and the anxiety. We'd actually got that baby some diagnosis that was a normal child. He hadn't been able to be referred to any other service, and Mum could just carry on. So that's about actually the real good outcomes that we get. There is loads of other ones because we have about 8 to 10 children that we bring to each meeting on average and that we review. School nurses is absolutely massive, the amount of children that we're bringing to MDT meetings. So that is a very beneficial system that we're adopting. So hopefully we keep going. It has good, really, really positive outcomes for children and families out there. So this is another one. This is another positive.
Hi. Let's just move. Am I going the right way or the wrong way?
The wrong way. Do you want to go back?
Sorry. Here it is. There it is.
I've got them. Yeah.
So this is one of the pathways that came away from the hub. This is our initial vision at one of the first meetings that we attended. So basically you've got the universal services, and from that they can refer into our infant feeding pilot clinic, or to the dietitians, to the hot clinic, or back down to GPs. So that's just highlighting how much money is spent a year, over £72 million, treating normal baby conditions, reflux, colic and constipation. And £50 million of that is actually NHS expenditure, so it's costing us a lot of money. Along with these conditions, there's a lot of parental anxiety. There's lots of distress for the infants and also for parents, which is why they're attending A&Es, GPs and hospital settings. So the reason why we set up the clinic was to try and reduce the number of babies who are clinically well, attending GPs regular, attending A&E and urgent care, and also paediatricians getting inappropriate referrals really for well babies. We know in practice there's a lot more medications being prescribed now to manage these conditions. For colic alone, there's over £6 million a year spent for GP consultations and prescribing of medications to manage, and parents are spending over £13 million buying over-the-counter medications, and there's very little evidence to say any of that is beneficial. Also, with the infant allergies, there's a lot more infants being prescribed specialised milks to manage allergies, and that is over-diagnosed. There's been a study that highlighted 381 children developed an allergy to some milk, and when they did true allergy testing, there was only 138 of those infants had a true diagnosis. So that was a massive 64% over-diagnosed, wrongly diagnosed. So parents are attending because they're scared, they think that something's medically wrong with their infants. They're crying, they're being sick. And the reason for that, some of that is just normal infantile behaviours. They've got unrealistic expectations. Parents in this day and age are very busy. We're on Twitter, we're on social media a lot. And I think as society in the UK, what decides what a good baby is, it's getting a baby in a real good routine, sleeping through the night quite early, feeding them very regular. But we know with evidence that this isn't what being parenting is all about, really. We want to be responsive to our children and responding to their needs appropriately. So the plan moving forward, as health visitors, we're in the best place for this. This is our bread and butter. This is, we know, we're experts in nutrition, infant feeding, in maternal mental health, attachment and bonding, and it all fits in. We've got really good relationships with our external multidisciplinary team members, dietitians and GPs and paediatricians. So the pilot is, we started this and we've only rolled it out initially to 3 local GP practices within our area. So it's just rolled out to Whitworth, Waterfoot and Bacup GP practices. If the GP has a baby that's coming to them and it's a well baby, but they're presenting with these feeding issues, they're referring to our clinic where we'll do an assessment, we'll do a feeding observation, and really we're there to contain and reassure mums that actually these behaviours are normal, just trying to demedicalise. So this is the GP pathway that we devised and sent out to practices. If a GP did have an infant that presented and they felt it definitely was an allergy, they could deal with that per NICE guidelines. But if they felt it was attachment issues, reflux, constipation, colic, they can refer into our clinic. So I'll just run through a couple of case studies. This is one of the clinics. This is written retrospectively. She attended just a normal drop-in well baby clinic, 23-week-old baby. And this is just the history that she gave me. She'd been to the GP on 4 different occasions. She'd been to the hospital twice over the weekends. She'd been seen by a paediatrician and she'd been on 3 different milks. So the cost of that is massive. Approximately a GP appointment costs about £45 for a consultation. A&E attendance is about £124. with those milks alone, there's hundreds of pounds worth of products there being prescribed. Nothing made a difference to this baby. The baby was suffering with colic and being irritable. So mum introduced herself back to first stage formula at 23 weeks, and she just wanted reassurance that that was okay to do. So the outcome, if they'd have come to our clinic, we'd have been able to do a full feeding assessment with her, and I'd been able to contain and reassure her. So all that time and money to NHS would have been saved. That baby wouldn't have been on unnecessary medications and milks. So infant B, this is a baby that came to see me in the infant feeding clinic. So mum had been to the GP, baby was well, and presenting being sick. She'd had a couple of extra visits from the health visitor, and we did the full assessment. So you can't really see that, but we've got quite a detailed assessment. Basically, we want to know what the feeding journey's been like from birth to now when they're presenting. Want to know how she's initiating the feeds, how does she know when baby's ready to be fed, how does she know when baby's had enough milk, is there any medical conditions, any allergies in the family, was there a traumatic birth that may have contributed to that. And then all your general information really, stools, wet nappies and things. If they're vomiting, we want to know how often are they vomiting, what volume is the vomit, is it a normal vomit? What's baby presenting like when they're vomiting? Are they in distress and pain, or is it just a posit? And infantile behaviour as well. We want to know what baby's telling us. We want to be reading our baby's signs. Are they happy? Are they settled in between feeds? Or are they really tense and distressed quite a lot of the time? Red flags. These babies have been seen already and been seen and as clinically well. But the red flags are there, and we'd follow procedures as needed with those if anything was highlighted. And then the outcome, so we'd sum up with mum, just discuss with her what we'd felt and action plan that, and then we'd share this information with the GP that referred and also the named health visitor. So a feeding observation, what we want to do is know how mum's feeding baby. She's looking for those early feeding cues, or is she waiting for the late feeding cues when baby's getting red, agitated and angry and crying? How is she feeding baby? Is she holding baby close? Is she giving baby eye contact? Or is baby just laying a cot and being fed from a bottle? What's the infant's position when they're feeding? Are they sat upright again, or are they laid down flat? And the position of the teat and the bottle as well. You know, if they're being formula fed, the bottle needs to be at 45-degree angle so baby's in control of that milk flow. So we want to be responding to our baby's needs and feeding them responsively. And we want to be pacing the feeds as well according to baby. So are they trying to get all the ounces down them as it says on the tin? Or are they, responding to the baby's needs when baby's had enough? Do they recognise those? So the main thing really with the clinic is we want to give that protected time for parents to explain everything that's been happening and listen and be able to contain them. This is an acronym that we brought in recently in our trust, just to reiterate all these important factors to parents that choose to formula feed the babies. So going back to the case study on the baby B that came to see me, I was able to reassure mum and just explain that actually there was no red flags. It was a normal, healthy, well baby. Reiterated anatomy and physiology of digestive system, just to explain that immature gut can contribute to reflux. Reiterated all those early feeding cues and discussed responsive feeding. This mum really had a set regime. She gave him so many ounces every 4 hours and she was trying to stretch that amount out. So it was just reiterating that and recommending it, improving the feeding position. He was laid down quite flat, so he had no control over that milk flow. So he was possibly being a little bit overfed as well. So when we followed that mum up, she was really happy. She'd been seen by a specialist health visiting clinic and she was seen in a timely manner out in the community, so it wasn't medicalised, she wasn't in hospital, so it's a more baby-friendly place. In the early meetings that we had when we were discussing what would happen if a baby presented and we felt they had cow's milk protein allergy. So we spoke with the GPs and we spoke with the dietitians, and they were happy if we felt somebody presented with an allergy, we would ask the GP to prescribe a trial of hydrolyzed formula. And if those symptoms went away, that would confirm that diagnosis. And the dietitians are happy for us to refer straight into them with a copy of our assessment and feeding observation details. And that that would save in itself, them going to the GP and then being referred on to the paediatrician and by dietitian. That's something we can do out in the community. Moving forward, this is something we're talking about in the hub, maybe developing a PGD to cut out the GPs having to prescribe those milks. So just to sum up really, infant feeding behaviours, it's our core programme really, it's what we do day to day, so it's best placed with us in the community. And it's saving all that NHS time, all the GP appointments, A&E appointments, paediatric appointments. And also, it's avoiding unnecessary prescribing. In London, there was over a 1 year period, there was £7.7 million spent on specialised milks. And if 64% of that were wrongly diagnosed, it's just a massive waste of resources, really. We're in the community, so I've already mentioned it's a baby-friendly environment, and we do look to go forward and have more group sessions, so there's some peer support there as well for families. And this is just summing up really the benefits of the whole hub, which I think we've kind of highlighted already. Oh, and that's what Denise talked through, so that was just her case study on that one. It's there right on the end. And we won that for the hub as well. Has anybody got any questions? Thank you.
So I actually had a question. I was thinking, because I mean, some of this it's about how we're going to replicate this outside. Thinking maybe the baby feeding clinic possibly easier, LCFT, or much wider than just one practice or even one district. The GP kind of model may be slightly more difficult. Have you thought about how we could translate this across the patch?
It is something that we do want to, we are looking to hopefully roll this out between all our health visiting teams within Lancashire wide, but it's just in its infancy at the moment, just as a pilot to see how that goes, but hopefully it's something that we'd like to roll out and then eventually get referrals from A&E and urgent care and things as well.
Yeah, that'd be great. With regards to the sort of the GP paediatrician kind of links and hubs?
Yeah, I think to some extent that depends on capacity that people have, both from secondary care and primary care. But what we've also looked at, particularly when we were looking at ours, was how do we... These are children that we've taken to the MDT to discuss. How do we perhaps case find? And some of the discussions have been that if there's perhaps an area or a locality, some demographics that mean a lot of children are perhaps frequently going to A&E or presenting a lot at out of hours, then that may be a way of then looking and saying, actually, this patch, maybe this will be really beneficial from there, and trying to get interested people in. And I think that potentially is where we're just a little bit stuck now, in that we need to have a little bit of background ability for some admin and some stuff like that to now roll this out further. Yeah. But I think we've probably looked at, it would either be people that were keen and interested, because that's always a good way to go, and the other way would be to look at perhaps where the biggest need might be and the biggest benefits to families and to services, and look at going in that direction. Yeah.
A second question for me is really around commissioning. One of the difficulties we've often seen with paediatrics is we keep children out. That means less income. So we have to fund the paediatrician to come to you to have less income. How has that been worked out with commissioners?
I'll say no.
Not yet. So there's a question for the commissioners.
Yeah.
So we've copied your example, looking at neighbourhoods and trying to do the MDT. Yes. We have probably the same issue with you about engagement, and it's always the same GP partners who are willing to engage. Yep. And I agree with you what you said about timing, but I think some of it is just very difficult to get them to engage in the first place and see how good this could be. How have you managed that within your region?
We set off when we were looking at extending GP access to noticing that at paediatrics at school closing time there was a big demand. So there was certainly already a recognition in that locality, so a lot of people were on board. But I think perhaps one way that we have got round some of the areas or practices that haven't been so engaged is the health visitor and school nursing team have been really engaged. So if they've then come across a family that are registered with that practice, they can then go back to that practice and say, look, we're involved, and at least have that conversation to take that information from the GP side of it back to the meeting. Or more the other way, the GPs could liaise with the school nurses and health visitors and take it that way, even if they're not able to get to the meeting themselves. So I think we're hoping that that has been a way forward to try and improve engagement. And certainly so far the people that haven't been engaged, they're reassuring us that if the time was sorted, they would be able to. Again, I suppose it's a bit back to the commissioning thing, isn't it? If you're having to leave your service and you can't backfill that, it's workforce as well as obviously the financial resources to do that.